for this afternoon's session. So we'll go ahead and get started. They're telling us that we only have 8 of the 10 presentations loaded, so that may give us a little extra time for questions and discussions. So we'll have, you have 6 minutes to present, and then we'll have a couple questions between each presentation. So Thomas, I believe from the UK, will get us started.
So good afternoon, everybody. My name is Tom Wingfield. I'm a postdoctoral researcher in infectious diseases physician at the University of Liverpool. And I'm going to talk to you about a study that we did about the yield of contact tracing in northwest England and how that relates to the guidance, our national guidance from NICE. So from year 2000 up until about 2011, there was a rise in TB cases, in TB incidents in the UK. And PHE, Public Health England, and NHS England came up with this strategy, a 5-year strategy, to try and bring those rates down. And amongst other things, including new entrant screening of migrants from high-incidence countries, they also suggested that we focus on contact tracing. So the NICE 2016 TB guidelines said that we should offer screening in close contacts of patients with pulmonary or laryngeal TB. And actually in previous guidelines, they'd also said we should do screening for patients with extrapulmonary TB, but they didn't do that in 2016. And the reason that they said for that was that it wasn't cost effective. And they cited about 5 different studies from that, but they overlooked 2 substantial studies from Birmingham and from Edinburgh, both of which showed high rates of extrapulmonary, of active TB disease in contacts of extrapulmonary TB patients. So actually, in a lot of the regions of the UK, there was still, some of the TB teams were still doing contact tracing for extrapulmonary TB patients, regardless of these new guidelines. So we wanted to measure the active TB disease rates in contacts of patients with extrapulmonary TB in our region. And we wanted to compare these by the site of disease, so the country of origin, and also the length of time in the UK of the patient. And we also wanted to compare these to the new entrant screening program thresholds. So in the UK, with the guidelines suggested that if a migrant came from a country with more than 40 per 100,000 TB incidents per year, that they should be screened, and we should prioritize those who come from countries with more than 150 per 100,000. And the last thing we wanted to compare to was what was the yield from those new entrant screening programs of active TB. And the most recent study from Rob Aldridge down in London showed a rate of 147 per 100,000 people per year. So we collected data from the National Enhanced TB Surveillance System, which is an online database, and we supplemented that with regional TB cohort review. So eligibility were adult residents of northwest England who had been microbiologically or clinically or both diagnosed with TB, who had more than at least 1 contact, but less than 25, which we defined as a cluster. And we studied from 2012 to 2016. So just to say that most of the patients here we studied prior to the introduction of new entrant screening across the country. And so this is quite a busy slide, but essentially we looked at 3,000 patients, 2,000 met our definition of eligibility, 1,000 had pulmonary TB who had 5,000 contacts, and 1,000 had extrapulmonary TB, and they had about 3,500 contacts. And so the results here, from left to right, it's all TB patients, just those with pulmonary TB, and just those with extrapulmonary TB. The darker part of the column is latent TB infection rates, and the lighter part of the column at the top is the active TB disease rates. And you'll see, as expected, the pulmonary TB disease, patients with pulmonary TB, their contacts were more likely to have latent TB infection or active TB disease. But still, in terms of extrapulmonary TB, the number was 440 per 100,000 screened, which is actually higher than either the threshold we use for screening or the yield in new entrant screening tests in the UK. But obviously, some of those patients would have been eligible for new entrant screening, and their contacts would have been eligible for new entrant screening. So we wanted to look a bit further into this. So again, from left to right, we just looked at those who were born in the UK, and in the middle there, those who were not born in the UK but had come to the UK a long time ago. And on the right there, those who were not born in the UK and had recently come to the UK. And as I think you would imagine, those people who weren't born in the UK, who'd come to the UK recently, their contacts had a higher likelihood of latent TB infection or active TB disease. But what's notable here is that even in the UK-born, the contacts of UK-born patients, the rates of active TB disease in their contacts were 160 per 100,000 screened, which is actually similar to the yield from new entrant screening. So in conclusion, the prevalence of active TB disease in contacts of adults with extrapulmonary TB is high, even when you exclude contacts who might have been eligible for new entrant screening, so 160 per 100,000 in those born in the UK. And that number was greater than new entrant screening program threshold criteria, and similar to the yield from the Aldrich et al. Paper of new entrant screening. So we think that this should open up some debate with other recent evidence that will be presented later today about whether or not we should be screening in the UK those contacts of patients with extrapulmonary TB. Thank you.
Thank you, Tom, for an excellent presentation. We have like 2 minutes for questions. So if anyone from the audience wants to ask a question to the presenter. I think you have to stand up and go to the, or is there another mic? Yeah, sorry about that.
Hello, thank you for the presentation. My name is Regis from Zimbabwe. I just wanted to understand in terms of the screening that you were proposing, you were screening how? Was it screening for extrapulmonary TB or screening for both pulmonary and?
So it was the screening of household contacts of patients with TB. And so it was screening for latent TB infection, either sometimes by skin test or by IGRA, and screening for active TB disease by symptoms in the household contacts of patients.
Okay.
So any other question? No? Okay. So thank you very much. And thank you for keeping the time. So our next presenter is Leonardo Martinez, who's going to present a systematic screening of household contacts of tuberculosis cases in sub-Saharan Africa, derivation of a predictive risk score.
Thank you. So my name is Leo. I'm going to present some data from my PhD dissertation. And this is not published data yet. So just some background. So 3 million TB cases are undiagnosed globally every year, is what's estimated. And so additional tuberculosis control intervention strategies need to supplement what is currently implemented, especially in areas such as sub-Saharan Africa that have high numbers of undiagnosed patients. Household contact tracing has been proposed as one potential complementary control measure. But programmatic implementation has been very poor. It's higher in high-income countries, but very poor in sub-Saharan Africa. Different estimates, but between 20 to 50% of contacts are screened, leaving a large percentage not screened at all. So our objective was, in the context of a large Ugandan cohort of household contacts, to develop a risk score that could potentially highlight high-risk contacts for coprevalent tuberculosis. So this would be a tracing mechanism, a contact tracing mechanism, to minimize the programmatic intensity of contact tracing. So this is a basic study design of the study. Basically, tuberculosis index cases were recruited, households were visited, and contacts were recruited into the study. There was an incident part of this study, but for this analysis, we only analyzed the baseline evaluation, which was tuberculin skin testing and coprevalent disease. Tuberculosis was diagnosed with chest radiography, microbiological testing, and clinical evaluation. And as I said before, the outcome is coprevalent disease, which was defined as 3 months after baseline or before. Oh yeah, and this was in Kampala, Uganda, sorry. So there were 499 tuberculosis index cases recruited in the study, over 1,900 household contacts, of which around 5% had coprevalent or were diagnosed with coprevalent tuberculosis disease. As I said, around 5% had coprevalent disease. The median age of the contacts was around 12 years of age. There was high HIV positivity, so 10% among contacts and 40% among index cases. So very high HIV prevalent community. So I don't have a lot of time, so it's a busy slide, so I'll run it as well as I can. But some risk factors in our multivariate model that we identified were young age, which is a known risk factor. So those 0 to 4 years old, those 15 to 24 years old, past active tuberculosis, HIV serostatus of the contact, lung cavitation of the index case, and family size of the household. So those that had low family size or small numbers of family members were at highest risk for coprevalent disease, probably because of closeness to the index case in smaller households. And so the idea of this study was to give a point score for risk factors for coprevalent disease, and then add up the number of points that each contact would get. So we assigned, based on regression coefficients, which I don't have here, we assigned 3 points for very young age, 0 to 4 years old, 1 point for 15 to 24-year-olds, 2 points for HIV serostatus and active disease, 1 point if you were exposed to a tuberculosis index case that had cavitary disease, and 1 point if you had a very small household. So then we stratified our contacts by the point total of each contact. Those with very high numbers of point scores, there weren't very many of them because they would have to have all the risk factors. You can see, you can see here, this is the prevalence of coprevalent disease. And as the point score drops, it is very low. It's around 1%, but it increases with the number of points that is given for each household contact, which makes sense. So this was a significant p-value for trend, and the area under the curve was around 0.80 for this algorithm. When we stratified by those that had 3 to 8 points, you see that the prevalence of tuberculosis at baseline was 14%, while those that had 0 to 2 points had around 1%. And if under this algorithm, the number of contacts that would be screened, so the number that had 3 to 8 points was around 27%. So you would screen 27% of contacts, but you would detect almost 80% of coprevalent disease. So you would make household contact tracing much more efficient, but also detect a large percentage of the disease burden. The area under the curve, as I said before, was 0.80. I'm not going to talk about it too much, but we did cross-validation, and it cross-validated well. So just to conclude, this risk score may be useful to minimize the resource intensiveness of household contact tracing in sub-Saharan Africa. External validation is definitely needed, especially because this is such a high HIV disease burden area. So other areas that may not have such a high disease burden of HIV may not have the same results. We are in contact with 3 other groups that have contact data, and we're trying to externally validate the risk score now. There's a lot of collaborators, too many to name, but these are some in the picture and a lot more listed. Thanks so much. Thank you. Thanks.
So questions from the audience? Frank? I think the only microphone we have is over there.
Yeah, I can hear you. It's good. Sorry. No, we actually didn't look at that, so I don't know what the risk score, how the risk score validate. It's a good question, though, and maybe we should look at that also. So definitely a good question. Definitely, yeah. No, I understand. Yeah. Yeah.
Thank you once again. I just wanted to ask in terms of the sampling that you did, where you were using index cases to get to the contacts. Were there any of the index cases that refused for you to actually get in touch with the contacts? And did you also factor the losses that happened in your analysis?
So did any index cases refuse recruitment? Is that what you're asking? Yeah, some did. I think the numbers are relatively low. We did a secondary analysis where we compared those that refused and did not refuse. So we did some analysis, but otherwise we didn't adjust for anything. Hey.
Yeah, just a quick one.
Yeah.
You talked about tuberculin skin test in the methodology. What was the role of tuberculin skin in contact tracing? And do you want to recommend it in our algorithm for contact tracing? Because it's not a routine test for contact tracing in Uganda. So is that a recommendation you would make for us here? I want to understand that. Thank you.
So let me make sure I understand first. So we did measure tuberculin skin testing. That wasn't our main outcome, so I didn't report those results. The results were very high. I think above 70% had skin test positive, above 10 millimeters. Surprisingly, though, or depending on maybe who you talk to, that did not predict disease. Those that had positive skin tests had an elevated rate of disease, but it wasn't statistically significant. So I don't know. Hopefully I answered that question. Okay.
Okay, thank you, Leonardo.
Cool.
If there are any more questions, you can connect afterwards, but we'll keep, at the end of the session, but we'll keep moving on with the next presentation.
Yeah, I actually have to leave, so just you can email me if you have any questions. It's not a problem.
Okay, great. Thank you. So it looks like our next presenter from Afghanistan is not here, so we're going to go to the next presentation. Herbert Kisamba from Uganda, Increasing TB Case Notification Through a Quality Improvement Intervention. Welcome.
I'm not Dr. Kisamba, but I'm presenting on the behalf. He did not come for this conference. Yeah. So it's about increasing TB case notification through quality improvement intervention. Yeah, just as a background to the national situation in Uganda, the recent prevalence survey found that the prevalence of TB is 254 per 100,000, and the mortality is about 14 cases per 100,000, and an estimated incidence of 234 per 100,000. And this translates to about 89 expected TB cases. But the program data for 2015 showed that the country notified 43,000 cases. And also from our DRS drug-resistant TB survey, MDR TB is estimated at 1.4% among the new cases and 12% among the previously treated TB patients. And that's the current performance in terms of case notification and treatment success. So the aim of this intervention was to improve TB case notification through a systematic quality improvement approach and contribute towards a reduction in the missed cases of tuberculosis. So our methodology, we applied the quality improvement intervention, and there are basically two models that was employed here. The model for improvement, and if you look at the extreme right-hand side, that's the model of improvement. It basically talks about identifying the problem, what you want to address, and then the interventions you put in place to address the gap, and then testing interventions or strategies to address the gap. And then we also applied the breakthrough series collaborative improvement methodology by Institute of Healthcare Improvement. And this is what basically it's all about. It's about a planning stage where you identify the facilities to implement the intervention, and then developing standards and indicators to measure the performance, and setting out the teams. Then training these teams, putting in place interventions to address the gaps that will be identified, and then the facilities go back to implement these interventions. And then they share their improvements through what you call learning sessions. So that is a summary of the improvement intervention that was employed in this activity. And these are the results of the intervention. So we present results of 3 facilities from 3 districts in eastern Uganda. It's clear from the intervention that the number of presumptive TB cases that were identified improved from the time of intervention, that was in December 2015, and we demonstrate improvement up to around March 2016, although there was some decline towards May 2016. But overall, there was an improvement in the identification of presumptive TB cases. Also, of those presumptive cases who were tested for TB, we also demonstrated improvement in the TB cases that were identified around the same time period from from December 2015 up to May 2016. During this intervention period, we also demonstrated the number of improved number of TB cases who were identified. So the key message we want to bring out here is that continuous TB notification process analysis. Here we are talking about the TB cascade from the point of identifying the population at risk who come to receive services, making sure that we screen TB among that population, and then those presumptive TB cases, subjecting them to a test. In Uganda, we use GeneXpert for all presumptive TB cases where the test is available. And then those who are tested, the TB cases who are identified, starting them on treatment promptly. So that's the cascade that was improved through the quality improvement approach. This approach, we believe, offers a great opportunity for increasing the TB case notification and identify the challenge of the high missed cases of TB in the country. I would like to acknowledge the facility staff, the Minister of Health, and the implementing partners who supported this process. Thank you.
Thank you very much. Do we have any questions for this presentation? I have a question. So are you involving nurses in the clinics and facilities as part of the screening clients for health, for TB and managing TB? Are you including nurses in the screening process, or having nurses actively screening and identifying cases of TB?
Yes, as I said, if you look at this, I wanted to show you, I hope I'm operating it well. This schematic diagram, the facilities that were involved in the earlier stage of the collaborative, we identify health facilities and build teams, the facility improvement teams, and that team is composed of the key health providers involved in the process of TB management. So this involves identifying the nurses, the clinicians, in the outpatients, the laboratory, and also those involved in counseling. So they form a team, and that's the team that works out the gaps in the case notification. And then they come up with solutions, and those are the solutions that they test through the improvement cycle, the PDSA cycle. So it's a continuous process, but the same team works together. And then they come at intervals to share experience of what they have done and the challenges in implementation, and they go back and implement. So it's a continuous process. Yeah.
Thank you.
I have also one question. Did you observe any difference in the increased notification depending on HIV status?
That data, we don't have the analysis here, but it will be an interesting one for us to do further analysis. Instead, what I would rather mention that what we probably observed is that in facilities that we are not implementing quality improvement interventions, the notification was not very good. And that's the reason why nationally we have declining case notification rates. And we believe if these interventions took place if in all the facilities, then we'll be able to address the gap. But it would be nice for us to do further analysis by HIV status to see the notification rates. Yeah.
Thank you for the presentation. I just wanted to understand from the methodologies that you were using. You said you did sort of like a bottleneck analysis to determine the interventions that you needed to take. So literally what that meant was that the interventions for the three sites most likely were very different. So how did you make sure that you actually say this intervention was a result of this, because there were three different interventions for all? How did you try to make sure that you sort of like standardize the intervention so that you are assured that this one intervention is the one that resulted in the impact that we are actually seeing?
Okay, the intervention we present here is a package. And it is what I said at the beginning, when the facilities were identified, we had to define the intervention package for TB notification. For screening, what do? We employed systematic screening at point of entry. And then make sure all those presumptive cases identified go through the standard testing, which we are using expert as the initial diagnostic test, and making sure those who are tested get linked to care. However, these were defined in standards and indicators which each facility was monitoring. So when they come together for learning sessions, they actually present the results of those indicators to show what they were able to achieve in those indicators. So they were defined at the beginning of the intervention, but they were implemented as a package, which is defined in this in this collaborative model. So the detail, when you get the details of the collaborative model, how it works, it's about identifying a package of interventions and then supporting the facilities to implement that package together. I don't know whether that answers you.
Okay, thank you very much. And if there are any further questions, you can discuss at the end of the session. Thank you very much. So our next presentation will be presented by Meredith Brooks, Identifying High-Risk Individuals for Tuberculosis Screening in Health Facilities and Communities in Western Kenya.
Hi, I'm Meredith Brooks. I will be presenting on behalf of my colleague, Dr. Courtney Yuan, who is tied up right now in another presentation. I have heard her talk about her work before a lot. I haven't been involved in the research, so I have my cliff notes here, and hopefully I'll do her work justice. If anyone has any questions at the end, if I can't answer them, I'll make sure to provide her contact information. So I'm presenting work from a case-finding study performed in Western Kenya. We conducted symptom screening, followed by gene expert within health facilities and in communities. Symptom screening included asking about cough, fever, night sweats, weight loss, and breathing difficulty of any duration during the past 4 weeks. For health facilities, any individual that entered a health facility was screened. In communities, mobile screening units were set up in central locations for 2 weeks at a time. Community health workers canvassed the community to encourage people with TB symptoms to attend. So we did a lot of active case finding here. People with respiratory symptoms and any HIV positive people with any TB symptoms were eligible for sputum collection. Diagnosis was done by gene expert and clinical evaluation. In health facilities, we saw that 20% of symptomatic adults were diagnosed with TB, while in communities, only 3% were diagnosed with TB. In addition, health facilities with screeners notified 31% more cases than expected based on control area facilities during this intervention period. This table shows independent predictors of TB among people screened in the health facilities and in the communities. So in the middle column for the health facilities, among people in health facilities who reported TB symptoms, there were no particularly strong risk factors for TB identified. While younger age, male sex, and HIV infection were significantly associated with TB, the magnitude of the association was modest, suggesting that everyone in the health facilities was at somewhat of a high risk already. Among people in the communities who reported TB symptoms, male sex, HIV infection, and having a household member who had TB in the last 2 years were independent predictors of TB. We used data collected on symptom presence and duration to then find out if we could use a more specific symptom screen to reduce the volume of gene expert testing required without sacrificing on case detection. This table shows different potential screening symptom criteria on the left. It then shows the percentage reduction in sputum tests and the reduction in case detection that would have resulted. We were looking basically for criteria that gave us substantial reductions in the amount of testing required without sacrificing on case detection. We found that for people without HIV, asking about cough lasting over 2 weeks would have reduced the number of gene expert tests by 31%, while only reducing the number of cases detected by 10%. However, for people with HIV, there were no criteria we could use that would substantially reduce the number of tests without also reducing the case detection in the process. In conclusion, people who have TB symptoms and are in health facilities in this setting are at a very high risk for TB, with 1 in 5 symptomatic adults being diagnosed. Within the communities, men and people with recent household exposure were also at high risk for TB. Broad symptom criteria are necessary to ensure high case detection among adults with HIV, while cough lasting greater than 2 weeks seems to be adequate screening question for people without HIV. Thank you.
Thank you. Do we have any questions for Meredith? Yes, sir.
Thank you. My question is related with the last conclusion. When you talk about broad symptom criteria, I would like to know if you consider, beside the cough less than 2 weeks, another signs or symptoms more specifically related with HIV, such as candidiasis or anemia. Did you consider this as symptoms to include in those broad criteria? Thank you.
Sure. I know, again, I was not involved in this work, so I apologize for my lack of knowledge on the topic. I know that they did have quite a wide variety of different symptoms that they were looking at, and these kind of wound up being the ones I presented wound up being the ones that kind of were found the most within this community, and that the ones that kind of had the most impact while trying to diagnose cases. I'm not sure if that was in particular something that they had looked at, but it's definitely something that maybe they could work into another round of this testing.
Any other question? No? Okay, so thank you very much, Meredith. Our next presenter is Singh Matthew Cavani and is going to present Should we screen context of non-pulmonary tuberculosis cases?
Hi, so my name's Sean Matthew Caveney. I'm a PhD student at the London School of Hygiene and Tropical Medicine, and I'm going to present some results which will hopefully help answer the question of whether we should screen contacts of pulmonary TB cases in the UK. So in the UK, the National Institute for Health and Care Excellence, or NICE, provides clinical guidance, and until the start of last year, the TB guidance recommended that we screen all contacts of all TB cases, irrespective of the site of infection. At the start of last year, that changed to recommend that we only screen contacts of those cases with pulmonary or laryngeal TB, and the reason for that is because those are contacts. We wanted to limit testing to contacts of people with potentially infectious TB. However, no new evidence was presented to support that change. And there is some evidence that it may be worthwhile screening these contacts. For instance, whilst the yield of around non-pulmonary index cases is about a quarter of that of pulmonary cases in these two studies from London and Birmingham, it's still quite high. And we can see that if we compare to the prevalence amongst known risk groups in London, each of the homeless, drug users and prisoners has similar or lower prevalence to the yield of extrapulmonary index cases. Similarly, if we compare to the yield of UK migrant pre-entry screening, we see that even the yield of high incidence migrants from high incidence countries is half that of contacts of extrapulmonary index cases. So this and other evidence, to which we can now add what Tom presented earlier, made us think that perhaps there was justification for screening these contacts, and so we undertook a cost-effectiveness analysis to help try and understand that. So this is based mainly on data from London, and we quantified effective contact tracing with these four potential impacts. The first is the reduction in time contact spent symptomatic, which we quantified by looking at the difference between the average time to passive diagnosis and average time to someone being found through contact tracing for contacts of extrapulmonary cases. The second one is the cases prevented by giving preventive therapy to latently infected contacts, which we quantified by looking at the yield of latent infection, the probability that cases complete preventive therapy, and the efficacy of preventive therapy. The third impact we included was cases prevented by reduced transmission from contacts and prevented cases. Now, we don't know the number of infections, the rate at which infections are generated by pulmonary contacts to their second layer of contacts. So we just varied this over a plausible range. And then we looked at if you find cases sooner, how many infections will you expect to prevent? And if you prevent cases through preventive therapy, how many infections would that prevent using the symptomatic periods in London? And finally, we quantified the number of deaths prevented by looking at those first three impacts and multiplying it by the case fatality risk, converting the first impact into an average number of cases using the symptomatic period. We then calculated costs of contact screening using drug costs from the British National Formulary and NHS reference costs for most other costs, and converted each of those impacts into a number of QALYs gained using EQ5D scores from this paper by Croatia et al. So this is the results. The y-axis here shows the incremental cost-effectiveness ratio for screening contacts of non-pulmonary cases versus not screening. And it's the cost per QALY gained on the y-axis. And the x-axis shows the average number of new infections generated for those contacts with active pulmonary disease for each month that they're undetected. In the UK, NICE suggests thresholds of £30,000 per QALY and £20,000 per QALY as being cost-effective, which are indicated here with the dashed and dotted lines respectively. We don't have a good idea of what a plausible value for the x-axis should be, but if we compare it to the recalculated Stibler rule in papers by Van Leth et al. And Schruns et al. And use data from London for the proportion of smear positives and symptomatic periods, we would guess that a value of around 1 on the x-axis or slightly below that is the most plausible range for this parameter. So this suggests it's very unlikely that it will be cost effective to screen contacts of non-pulmonary index cases in London or likely the rest of the UK. We did a number of sensitivity analyses, but most of them, the qualitative results were similar. An exception to that was if we doubled the average symptomatic period of all contacts, which is a plausible thing to do if the symptomatic period is systematically underestimated, for instance, due to recall bias. And you can see that in this scenario, the intervention screening contacts of extrapulmonary cases becomes cost effective at a more plausible value on the x-axis. So in summary, it's probably not, our results show it's almost certainly not cost effective to screen contacts of non-pulmonary cases in London, supporting changes to NICE guidance. Screening these contacts was very expensive compared to new migrant LTBI screening, mobile X-ray unit screening, which is called Find and Treat in London, and also compared to tracing contacts of pulmonary cases, which in results we didn't show was probably less than £30,000 per QALY, and in another study from Canada was actually cost saving. A possible exception to this is if the contacts are themselves very infectious and create a lot of new infections, as might happen in, for instance, a homeless shelter, although in that group we have Find and Treat as a very cost-effective intervention already. Some limitations of the study, high uncertainty and high sensitivity to the symptomatic period estimates. And we neglected a potentially higher hospitalization rate of those cases found later without contact tracing, which would, if we'd included it, reduce the incremental costs, although we didn't have any data on that. I'd just like to thank my supervisors and all the people underlined there who are my co-authors on this study. And thank you for listening. Sorry, I ran over a bit.
Okay, now, Frank?
Hi, Frank Koblenz, University of Amsterdam. First I thought I understood, and then I wasn't quite sure that I understood when I saw your sensitivity analysis. Does that imply that you assume causality, that you assume that an extrapulmonary patient with extrapulmonary TB actually transmit to others? Because to me, it would probably be being in the wrong place at the wrong time, isn't it? It's a marker in a low prevalence setting, I would think, a marker of being in an environment where someone else is spreading tuberculosis.
Yeah, I maybe wasn't clear about this. So it was doubling the symptomatic period of all patients, but
right.
The relevant one for this is the symptomatic of the pulmonary cases who are contacts of the extrapulmonary cases.
Okay, so not of the extrapulmonary case itself, because otherwise it wouldn't...
Exactly.
Okay,
So it's their contacts who are themselves infectious, generating onward a second layer of infection.
Right, yeah, that would make sense, yes, definitely. Okay, thanks.
Any other questions for Sean? Okay, thank you very much, Sean. Our next presenter is Nita Perimel, talking about tuberculosis screening in asylum seekers in Germany, case characteristics and yield of screening.
Good afternoon, everyone. My name is Nita Perimel, and I work as an epidemiologist at the Robert Koch Institute in Germany. I would like to first thank all the co-authors because they've done actually the majority of work on this project. I'm mostly here to present their work. So I'm sure all of you know that over the last few years, Germany has received quite a large influx of asylum seekers and refugees. A lot of them come from countries with a much higher burden of tuberculosis in comparison to Germany itself. Therefore, today I'll be talking to you about the TB screening among asylum seekers in Germany, and I'll be focusing on the yield of screening and case characteristics. A little bit of background information on the epidemiology of TB in Germany. Germany itself is a low TB incidence country, and all active cases of tuberculosis are notifiable to the Robert Koch Institute. In 2016, there were approximately 6,000 cases of active TB cases notified to the Robert Koch Institute, which translates to approximately 7.2 cases per 100,000. Numbers were quite similar for 2015 as well. And also in 2016, 75% of the notified cases were among individuals who were born outside of Germany. So here you see a bar graph that shows the trend in the number of TB cases over time in Germany, stratified by the reason for diagnosis. As you can see, the dark blue section of the graph, which represents passive case finding, has been over time the biggest reason for diagnosis of active TB in Germany. However, since 2014, we've seen an increase in the number of cases being identified through active screening of asylum seekers, which is represented here with the light purple color. So Germany actually doesn't automatically screen people coming into the country, such as immigrants or long-term workers or refugees or asylum seekers for TB. However, the German Protection Against Infections Act, or the IFSG, does stipulate that all persons who are to be accepted into community facilities for refugees or asylum seekers or into initial reception centers of the federal government must submit a medical certificate stating that they show no signs of infectious pulmonary TB. As a result, this kind of meant that since 2014, the majority of these asylum seekers have actually been screened for TB. In 2015, there were 1,255 cases of active TB who were notified among asylum seekers who were screened in accordance with the IFSG. Here you see two pie charts. I'll focus on the pie chart on the right first. This shows for those 1,255 cases of active TB notified among asylum seekers who were screened in accordance with the IFSG, the 10 most frequent countries of birth. So as you can see, the top 4 countries they have very similar case numbers, are Syria at 157 cases, Somalia at 155 cases, Eritrea at 148 cases, Afghanistan at 146 cases, and Pakistan at 95 cases. And the remaining 5 countries are Kosovo, Gambia, Ethiopia, Iraq, and Albania. Just to put these numbers a little bit into context for you, on the left-hand side, you see a pie chart that shows the 10 most frequent countries of origin for the first-time asylum applicants in Germany for 2015. This is just to give you an idea of the numbers that we were seeing at that time. So here, delving a little bit deeper into the case characteristics, I couldn't show all the countries here in detail, but the bottommost row actually summarizes the numbers for the 12 most frequent countries of birth for those TB cases that I showed in the previous slide. But looking at the top 5 countries of birth, you see that in the right-hand column, you see the estimated case finding rates, and these were particularly high for asylum seekers originating from Somalia at 1,210 cases per 100,000. They were also quite high for asylum seekers originating from Eritrea at 580 cases per 100,000, and Pakistan at 331 cases per 100,000. They were considerably lower for cases originating from Syria at 37 cases per 100,000 and Afghanistan at 95 cases per 100,000. Focusing on the bottommost row with the totals, the majority of the cases were male, with a male-to-female ratio of 6.6, and the median age was young at 25 years old, and 3.6% of the cases were children aged younger than 15. 89% of the cases were pulmonary TB cases, and out of these pulmonary TB cases, 26% of the cases were sputum smear positive. This is lower in comparison to the 49% sputum smear positive cases usually found through passive case finding in Germany. 5.7% of the cases were MDR TB cases, but this is only among the 636 cases in total that did have drug susceptibility testing results available. So, in conclusion, considerable number of TB cases were identified through active screening among asylum seekers in Germany. Cases were identified early, as reflected through the low proportion of sputum smear positive cases, and this likely prevented future transmission of tuberculosis in Germany. Thank you.
Thank you, Nita, and you stayed to time, so thank you. Any questions for Nita?
Yeah, thank you so much for the presentation. Did I hear correctly when you mentioned that there was 26% positivity rate? Which other methods were you using to confirm the other cases? Did I hear clearly that 26% were positive of the people who were tested? Then how do you confirm the other cases?
I actually cannot hear you at all because I'm hearing everything from this side. Sorry.
Okay. What I'm asking that I had as if there were 26% positives on testing for TB. Which other methods were used to confirm the other patients who were treated as TB? Thank you.
You mean how we confirm that cases are positive, TB cases? So we have criteria in Germany for having active TB. So it can be symptom-based. Then there's lab culture positive cases, and then we do, depending on whether culture positive or not, they go through sputum smear positive, sputum smear microscopy. I'm not sure, because we have a pretty strict diagnostic criteria that is based on clinical symptoms and lab results. And when they meet this criteria is when they are identified as positive TB cases. Did I understand your question correctly? Perhaps not. You can ask me this question after.
Any other question? No?
No.
Okay, so thank you very much. So our next presenter is Shekhar Waikar from India, who's going to deliver a presentation titled, "Is it possible to increase TB notification from the private sector in India?"
Presentation is not coming. Sorry, presentation is not coming. Okay. So very good evening, ladies and gentlemen. On behalf of Shekhar Waikar, I'm presenting. I'm Dr. Preeti Shokin on behalf of Population Service International. I'm sharing my little experience on increase in TB notification from engaging private sector in India. So these are some outlines we are going to discuss in our presentation. So first of all, under the background and challenges, if we say about India, private sector contributes to more than 50% of TB cases treated in India. Most often, private sector is first point of contact for presumptive TB cases. Less than 8% of TB cases are notified to the National TB Program in India, which contribute to more than 1 million missing TB cases in India. So emphasizing on this million TB cases, our national strategic plan, which aimed to end TB, emphasized to engage more of the private sector. However, response from private sector is still discouraging, and they're showing disinterest in engaging with the government center. So if we say about the intervention, PSI is working under Global Fund, and for the project Akshaya is implementing urban intervention across 9 cities. So in urban intervention, what we are doing, we are identifying the potential private players, which includes the private practitioners, big hospitals, private labs. So on the basis how we are identifying, then mapping and prioritize on the basis of qualification, the footfall of TB patients. We are asking about them, about the barriers and the motivators, why they don't want to notify the TB cases to government. And we are regularly sensitizing them on TB standard care of India. We are regularly in touch with having the follow-up through our urban coordinators of the project, which are engaged with us through medical training specialists. On the basis, regularly they are doing the activities with them with the help of communication materials. So regularly follow up with them, help us to engage them with our project. Continuous support is also provided with terms like urban coordinators on the regular follow-up collected the data from these private providers, and they are going to giving to the that is the notification site. They are supporting the private providers, like in terms of entering the data on their behalf, or they are doing the follow-up their private patients, like if they have any problem, they are having the telephonic conversation with their, you can say with their patients that are there on the treatment, they are treatment adherence, maintaining their follow-up. So if we see the results, when PSI started the activity in Jan to December 16, in a quarter, the notification, it increases to 10,409. When we see the same period, that is when PSI was not working in the pre-intervention period, during the Jan to December 2015, it was just 2,400 cases. So overall, it shows that 5-time increase due to our effort, which lead to 65% of PSI contribution among the TB cases. So we can say from our experience that there is need of systematic approach to increase TB notification from private sector in India, which includes some points like, first of all, mapping of these sectors and prioritizing them upon the qualification, upon the footfall of TB patients, and identifying basically the motivators and the barriers why they are not collaborating with the government to notify the cases. What exactly is the problem and what kind of support they want from us. Support to private provider for notification and follow-up of TB patient is also a must thing. Like we are providing support, we have our urban coordinators, so they are going to each private practitioner and helping them in data collection and having a follow-up to their patient. In between, you should have a training and sensitization like with these providers to encourage them and to lead them to engage with us. And lastly, you can have a regular feedback to the providers, like we are engaging with them and we are talking to their patients telephonically or meeting with them. So you can provide the feedback to the providers about their patient, assuring that their patient remains with them and they are satisfied with them. So that's all from my side, and I would like to thank for the support of Global Fund, the Union, PSI Washington, and Project Akshaya team. Thank you so much.
So do we have any questions? So I have a question. Have you analyzed the difference in treatment outcomes, patients that were diagnosed through this intervention?
Yes.
And the second question would be, it seems like a quite cost-effective intervention, but have you done any costing exercise?
Okay. Regarding your first questions, so it's like we have our data routine MIS, which is on quarterly basis. So we have that data, that what is the treatment outcome from these patients, which are coming from the private providers. So after 1 year, we just checking out, see what kind of treatment is there, the cure rate, the completion rate, what is the iteration rate. So we have all over the data we used to compare in the yearly basis. So that is there, that what kind of notification is there and what type of outcome is coming. So we also analyzing the same in every our quarter-wise year MIS. And on your second question, you were asking about the cost effectiveness. So cost effectiveness we are maintaining in terms like we are training because we are not providing as such incentive to these providers. We are training and sensitizing in groups. So in an area, if you're like, we are mapping the, which are the potential. So we are mapping these providers and we are arranging a training and sensitization group for them. And we have urban coordinators to have, which used to have a follow-up on the weekly or the fortnightly basis. So overall, the costing is not as such, but there is more and more effort which need to be a regular follow-up these providers because we have to change their behavior. So cost effectiveness is there, and moreover, like we are treating, we are taking up that million missing cases, that is more effective way.
So first of all, congratulations on that result. But I was wondering to what extent, so this is primarily about private practitioners who diagnose and treat tuberculosis but didn't notify them. So you improved the notification. Do you have any data on whether they actually found more patients, whether they, with the scale up of your program, whether they increased the number of patients that they actually detected and started on treatment, or is it only about the notification of these patients that they were already treating?
Actually, we have different formats, and we have a case notification format. For each patient, we have case notification format, and that is provided with these providers. So when a patient is having a TB and is diagnosed with that provider, that format is filled up. So with each date and what is the outcome will be declared, it is maintained with the urban coordinator of our project. So on the regular follow-up, when he knows that this patient is going to complete his treatment or her treatment, so he is going to have that actual follow-up and having the actual follow-up with the treatment completion, he get to know about the status of the patient. So it's not about just starting up. So we have all the data, because regarding when we started, the notification which was pending from years to the private providers, we collected that notification data, we entered in the government software, and that made it a regular basis exercise for the private sector.
No, I get it, but did case finding go up? Because
Yes, obvious. Case finding also goes up, because it's like notification is increasing day by day. So there are chances when earlier we are not able to qualify what number of notification was coming from the private sector. But when we see cases, there are seen, like even the person, the private provider, earlier was notifying just 10 cases. But when we reach to them, now it increased to 50 cases per month. So there are more and more increase.
Thank you.
Any other questions? Okay, thank you very much. And last but not least, who's presenting this last one? Gaps in TB screening in health facilities have contributed to a decline in TB case notification in Kampala City.
Thank you very much. I'm presenting our observation of declining TB notification in Kampala, and we attribute this one probably to gaps in TB screening. Now, as we observe, tuberculosis TB case notification in Kampala has progressively declined over the last 5 years, from what we were finding as like 8,000 cases to now the early 7,000s. And we think a number of factors could be attributing to this. And this picture is observed amidst a finding that has just been reported by the national program, where the TB burden in Uganda is double than what you actually earlier thought. So we are grappling with a number of interventions, and one of them is improving TB case notification. Of course, what has been presented earlier, the contact investigation and the others are all being explored. But in this particular observation I'm sharing, that we try to find out whether what our contribution of TB screening could do to TB case notification in Kampala. So that graph shows the decline over time from 2013 up to date. And as we realize, it's very unlikely that even as time goes on, we are going to improve this in the near future. So what we did is that we collected the data from the triage points in the 10 high burden facilities in Kampala. These are facilities which notify in a total over 80% of all the TB cases in this city. And we did this by administering the intensified TB case finding form. And we collected information about cough for more than 2 weeks, fever, and night sweats. So based on what we found on the symptoms, we tried to establish the proportion of presumptive TB patients and the number we needed to screen to confirm one TB case. So in our results, in total during this period that we are reporting, we screened about 170,000 TB cases, presumptive outpatient cases, of which around 22% were the children below the age of 5 years. Overall, we found 95% of them were screened with the symptoms I provided earlier, and we found a presumptive rate of around 3% only. We have been grappling with this figure of increasing the number of presumptives, because elsewhere in literature it has been mentioned that maybe this could be around 10%. But in this city, we have never even come to 5% being presumptive in these facilities. Out of the presumptives we found 14% of them actually being confirmed with the tuberculosis, of which around 483, that is around 60%, were bacteriologically confirmed. And from our analysis, we realized that to confirm one TB case, you had to screen 232 presumptives for you to be able to, 232 people who come to the facility for you to be able to identify one TB patient. That is those are the screening rates from the different divisions in Kampala. Kampala is divided into those divisions for purposes of TB control. But as I realized, the overall screening rate was around 95% in all the facilities, with the list of the division performing 63% screening, but the rest were above that figure. Sorry. So we concluded that despite the high screening rates in Kampala, the yield of presumptive TB cases in Kampala remained low. It is around 3%. And we think probably this could be due to ineffective implementation of TB screening at the facilities. We also, since we know that usually when someone says doesn't have a TB symptom, we don't go ahead to investigate. Maybe by missing these symptoms at the facilities could be leading to these people not being further investigated and therefore not increasing the TB cases. And we think the low yield of TB might contribute to the declining TB cases that we observed in the previous slide. Yeah, I think that is the presentation. Thank you very much.
Thank you. Do we have any questions?
So thanks, Deus. And I'm familiar with the setting, so as you know. So I was wondering, so this is intensified case finding, isn't it? Because you do it at triaging when patients come into the OPD. So have you calculated what the additional yield was of doing this above what above the sort of regular numbers of patients that TB patients that these clinics find?
The additional yield?
Yes.
What the regular?
Yeah.
We have actually implemented this strategy over time. For example, it has taken us about 2 years. We are trying to observe whether there is an increase. And it has remained persistently around the same rate, especially the presumptive TB patients. They never go beyond 3.6, 3.5%. And in this particular case, they actually declined to 3%.
Okay.
Yeah. So there isn't a case like we compared where it's not implemented and where it is implemented for us to find out whether this particular intensified kind of case finding yielded more presumptives and more TB cases.
But then you find 3% low, and I mean, it's not necessarily low because you have 14.4%, I believe that it was, out of those who were presumptive TB cases who actually had tuberculosis, which to me looks like quite a high number. So you have to ask a lot of people, but in the end you only have to test the 4,000 something, and you come up with 700 TB patients, so 14% out of those. So then it's always very easy to divide 100 by 40.4 because it's 7. So you actually have a 1 in 7 yield, I would think. So you need to test only 1 in 7 to find an additional case, which I think is pretty good.
Correct. Yeah. Actually, I think maybe we have been overambitious because that has been documented earlier in some literature that when you screen it within an OPD setup, maybe you'll end up with 10% having TB symptoms, and they're being presumptives for that matter. The mere fact that we are having 3 cases, we think maybe in the 7%, if it is not being well done, maybe in the 7%, we are missing actually more cases. Yeah, and this one could be contributing. Yeah. Because when you confirm them as presumptives, when we test, we find a significant proportion actually being confirmed as tuberculosis cases. Yeah.
Thank you.
Any other questions? Yes. It's very hard to hear up here. Thank you.
My name's Asma Henry, and I work with a TB patient organization in Moldova. And there is a lot of stigma, and my question really has more to do with the presentations that were on contact tracing, because it's very hard for us to do that because of the stigma. No one wants to tell you who they work with. They don't want their coworkers to know they have TB. And yes, their household contacts, that's a different matter, but to say, well, you know, which bus do you ride where you're maybe transmitting, and, you know, who do you work with? And the stigma is a big factor, and I didn't really hear anything about that when it comes to contact tracing. Anybody wants to say something? Yeah?
Yeah, I think maybe to share just a little bit of experience from Uganda, because like I mentioned earlier, we are implementing a number of interventions to find TB cases. And actually one of them is contact investigation. And what she's mentioning, actually stigma is key. The teams we use to go and carry out this contact investigation, some of them, most of them actually, a significant proportion is told lies about where these patients come from, because they don't want their relatives or their immediate neighbors to know that they actually have tuberculosis. Others have been given wrong telephone contacts, others have been given wrong addresses just for purposes of, or others have been told not to go with identifiers that they're actually going to trace them as TB patients to carry out TB contact investigation. So you are told to go dressed in a way that will not be able to identify you as someone who was going to do contact investigation. So like someone's mentioning, it is actually a challenge that is affecting this kind of intervention. I don't know what others have to say.
Any other questions? Thank you for raising the issue of stigma. I know that's a big issue everywhere. Do any of the other presenters have anything else they wanted to say about stigma and contact tracing? No? No? Okay. Thank you very much.
Okay, so I don't think any of the two missing presenters are here. Otherwise, we are going to close the session. So thank you very much for your attendance. Thank you.